Thanks, Juan. So, we heard a great number of talks, and we're going to kind of take a step backwards. So you heard about the frontier, or the kind of emerging technologies of lateral. This is going back to the basics. So first lateral I did was in 2007. And back when I did it, there was no technique manual. They had tools that were very TLIF oriented. And I think the comment was, we were kind of turning TLIF surgeons into lateral surgeons. And so there was kind of not a real good technique manual, so to speak. The person that I learned lateral from, he had done 9 cases. And again, he was kind of my mentor, or kind of the person who taught me. And so what I've kind of learned about the evolution of lateral is that when you talk to guys who have done lots of levels, lots of volume, is that the technique really becomes very similar. I use very few instruments, and there are certain things that I've kind of picked up. And I will say, we always talk about kind of thigh pain as far as one of the pitfalls of lateral surgery. There's no question that my last 50 or my last 100 have done much better than my first 50 or 100. And I think a lot of the kind of changes have been techniques, how to handle the psoas, how to handle the lumbar plexus. And so we'll kind of go over some of those things today. So the first thing with lateral surgery, whether you're prone or direct lateral, is that you want to get the patient perfect. You don't know how good your C-arm tech's going to be, and so you want them to go orthogonal, just 90 to 90, and keep it really simple for them. So the first thing is that we want to position the patients so they're in the perfect orthogonal position. So you want your AP to have the spinous process in the middle, or if they've had a prior laminectomy, the pedicles are going to be even. On your lateral, again, you want good end plates. That might not be possible with patients with scoliosis, but in general, good end plates, pedicles that are equidistant, spinous process in the middle, and that's kind of how you want your basic setup. The first step in starting your kind of successful lateral is to, again, mark your patient. And what I'm going to do is the first line I'll make will be kind of in line with the disc space. So we'll take a shot there, and let's see. And I don't know if the floor images are also kind of being, shot there. So, I want my line that's going to be in line with the disc space. And do you have a marking pen? So I'm going to make a line that's going to be, kind of in line with the disc space, but it's going to extend beyond the anterior and posterior margins. And really kind of does 2 things. First, it's a reference point to allow me to know where my retractor is going to be placed, and if I'm going to be in line with your disc space. It also allows me to tell the X-ray tech where to kind of come in. So it serves as like a point of reference for both myself as well as the X-ray tech. The next line I'll make will be approximately at the posterior margin of the disc space. Take a shot there. And then what I'll do is I'll make that mark as well. And then I'll kind of go to the front of the vertebral body and the disc space, and I'll make another line anteriorly. So then, do you have a knife? So then what we're doing as far as incision is I'll make it, from anterior to posterior, and I'll make it kind of in line with that line that I drew. And then what we'll do is we'll just kind of bovie, and we'll kind of pretend that I'm using a bovie at this point. And I'm just going through the fat until I get to the musculature, but I don't want to bovie through the muscles. And so, when you're at 4 or 5, you have the ilioinguinal, iliohypogastric nerves that can kind of cross that brim. And again, if we're trying to avoid thigh pain, one of the worries that we kind of get those nerves, and it can cause dysaesthetic pain or thigh pain. When we get higher up, 2, 3, for example, if you go through the muscle, you can get the nerves that go into the abdominal wall, and patients will present with this kind of big hernia that they say, or this big kind of outpouching. You'll get a CT scan, there's no hernia, but what happens is the nerves that go into the abdominal wall get denervated, and you get this kind of atony of that ventral wall, and they come in with this big pocket of bowel that's contained, but it's kind of unsightly, and patients don't like it. So once I've kind of gone through the fat to the level of the muscle, do you have a Mets?
This is what I got.
Perfect. So then we'll kind of go through the 3 layers. I'm not probably going through each of the layers individually, but I'll kind of do more of a poke method. And once you kind of you'll kind of reach the transversalis fascia, and it's definitely an audible feel and an audible pop that you'll feel. And then I'm kind of using just this reverse kind of scissoring technique, and you'll find that transversalis fascia is kind of like a casing on a hot dog. And so it's something that, once you kind of spread it, you really want to be aggressive in terms of, how much you're opening it. The next step I'm doing is getting kind of into that retroperitoneal space, and I'm feeling for a couple things. If my finger is long enough, I can feel the psoas and the TP. Oftentimes it's not. And so to make sure that I'm in the retroperitoneal space, the first that you feel, it just has this kind of cottage cheese type consistency, and you kind of feel that retroperitoneal fat. Then what I'm going to do is I can kind of sweep and feel the undersurface of the ilium, and oftentimes I can sweep and find the undersurface of the 12th rib. And that kind of lets me know that I'm in a safe position and I'm in the correct retroperitoneal space. I still will use a 2-incision technique if it's a super, super skinny patient. So someone who, let's say, is that 75-year-old, 90-pound soaking wet patient is that, they don't have a lot of retroperitoneal fat. And even on an MRI, I'll kind of look at how much fat that they have. And if someone is super skinny, they don't have a lot of retroperitoneal fat, I'll go ahead and do a 2-incision technique to make sure I'm not in the peritoneal contents. This person, there's definitely plenty of retroperitoneal fat, so no worries there. And we'll go ahead and take that first kind of wire dilator. And so do you have a holder? I'll take the first dilator. Thanks. Okay. And then do you have a dilator holder? And we'll bring in C-arm. Do you have a dilator holder or some kind of sponge stick even? I can use that, yeah. Okay. So we'll go ahead and bring the C-arm in. Okay. And then we'll take a shot. So depending on what level, I can go to the one above. And then take a shot there. Okay. Can you push in a little bit? Okay. Shot there. Okay. An X-ray there. A little bit too much. And then shot there. Okay. An X-ray there. Okay. So then, do you have like a mallet? Can you raise your image a bit? So we're kind of aiming for about that 30 or so yard line. And then we'll take a shot there. These ribs are kind of pinching me. So, again, we might be at the 50 there, which is okay. And so what I'm doing is I'm really trying to dilate through the psoas muscle as we're going kind of trans-psoas. We'll take the next dilator, and you can just pull back for a sec. Great. And so as I'm going, we don't have it specifically set up, but I'm typically neuromonitoring or using the surgeon-driven triggered EMG to monitor the lumbar plexus, and we'll pretend I'm kind of doing that. And so really at this point, I've kind of dilated through the muscle, dilated through the psoas, and we'll go ahead and put our retractor in.
Can we talk to pause for a second?
Okay. And then so again, the other thing that initial line kind of served me is now I'm going to try to align my retractor kind of in line with the disc space. Retractor's kind of parallel to the floor. Do you mind grabbing this? Okay. I'll just put that on. Okay. Maybe if we turn that around. Perfect.
Can the elbow be over here so it's not hitting him?
You good to go? Okay. Might have to turn it around the other way. Yeah, it'll still be out of the way. Okay.
You're back up, Dr. Kwon.
Tony, you're back up. You can see you.
Okay. Are we back live? Okay, perfect. So I don't know where we kind of left off, but again, we went through the psoas, dilated, and then we're trying to put the retractor, can you listen for 1 second, in line with the disc space, kind of parallel to the floor, and then we can lock it there. Okay. And then now we'll open up our retractor. The other thing to open up. Perfect. Okay. And then we'll go ahead and take a shot there. Perfect, yeah. Good. So, if anything, we're in line with the disc space, so you can kind of see the arms in line. We're probably a little bit more anterior than, what I want, which is fine, so we'll make a little correction there. So are they going down these? Okay. And then, okay. And then we can back out for a sec. Okay. Perfect. And so if I'm trying to do any kind of manipulation of the retractor, I always want to do it under direct visualization. And I'm using my kind of wire to provide a reference point. So if you can kind of see the wire is, maybe in the middle of the retractor. And so I'm going to try to move it so that the wire is in the anterior portion of the retractor. And that's always going to be kind of my reference point. Do you mind loosening this for a sec? Okay. Then now we'll lock it there. Okay. And then let's go ahead and take a shot there. And so now we can kind of see maybe a little bit low, but we'll go to an AP now. We can make adjustments as needed. Okay, now can we change our wag so it looks like it'll be maybe that way? We'll try that. If it looks worse, open up your wag. It looks like the other way. Okay, I'll try that.
Yeah. So I gotta bring it back here now.
Can you go up north? Okay, so not bad. Okay, so at this point, I'm losing this again. We'll kind of move it just a little bit more. Okay. And then shot there. Okay, good. So the rib's kind of pushing us a little bit, which is fine. And at this point, we have kind of a O-lift type setup, but traditionally I would put a discal shim at this point once I've stimulated and so forth. So let's go ahead and grab the disc knife. So now we'll use our knife to make our annulotomy. Okay. And then the first instrument is going to be our cob. And so this is what we tell the residents and fellows is that, really your cob work is going to be, the most important because this detaches the disc off of the end plate. And so we'll take a shot there. So here I'm kind of, again, not quite on end plate. So this is both a tactile feel as well as kind of an audible feel. And so I'll grab my mallet. And then I'll kind of go across the contralateral annulus. I know Neil's cringing right now, but we'll go ahead and do this. And so now we're across on the upper end plate, and we'll go across. And the one thing I'll do, especially with these bigger disc spaces, is I'll use the angled cob to really make sure I'm kind of releasing the disc off the end plate. And then we'll take a shot there. So, here I'm really kind of scraping along, making sure I'm getting across without going into the end plate. And kind of the same thing. So now once I've done a release of the disc off the end plate, I'm going to use the box cutter to go ahead and create my channel discectomy. And then take a shot there. A little bit low. And then shot there. Okay. And then x-ray there. Okay. Okay. And then so generally you'll get either, if you've done a good release, you'll get a lot of disc within the box cutter, or your pituitary will get, big pieces of disc out. And so, really the difference between an effective discectomy and a non-effective discectomy is really the cob and the box cutter. The pituitary is going to be your worst enemy as far as a long discectomy for a lateral. So the more that you're picking, the kind of worse of a job you've been doing as far as efficiency goes. And so I'll tell the residents and our fellows that, once the retractor's in, you are kind of under a time crunch. So, if we're not putting trials in by 15 minutes, we're not being efficient. So, really, those are the only instruments that are really used as far as disc prep before I do my trials. So can we do some trials? So we'll go ahead and we'll put our trials in, and then shot there. And so, once we have our trials in, I'll kind of sequentially go up typically. And at this point, I'll go ahead and get a lateral. So push it in just a hair. And so, that's our trial. So at this point, I'm pretty happy with, my position. If I'm being critical, maybe it's aimed a little bit posterior, but not much. Can we go back to an AP? And so at this point, now I'm going to tell the back table what implant I want. So I can use the trials to judge size, height, and so forth. So whatever we have loaded up. And so the reason why I want to go ahead and do like a rough discectomy now is for them to assemble it, put the bone graft and so forth. That just takes time, and it seems like every second's a minute, every minute's an hour when you're doing these procedures. So I don't want to waste any time. And so while they're assembling it, then I'll use my kind of uterine or kind of push-pull type curettes, and then I'm doing my fine tuning as far as disc prep goes. So now I'm kind of really getting that good kind of orthopedic sound. We call it the sound of fusion in my OR. But we'll really go ahead and make sure that we're getting, again, kind of good end plate preparation without violating the end plates. So, really when it comes down to it, if you think about the tools that we use, other than the annulotomy knife, cobs, box cutter, trials, your ring curettes, that's all that I use. And so a lot of these sets will have like the shavers, the kind of T-lift type curettes, and I typically don't use any of those. And so once we've kind of done the end plate preparation, they've assembled the implant with the graft in. Again, I know we talked about biologics. I typically use some form of fibrous DBM or allograft. Again, for revisions or certain patients, I will use BMP. If I do, it'll be usually an extra small with some kind of cheap filler. And then we'll go ahead and put in our implant. Okay, give a mallet. Shot there. And so there's our implant going in. X-ray there. Shot there. And then X-ray there. X-ray there. A little more across. Then shot there. So, somewhere in that vicinity, but pretty much, that's kind of the last step. And so, some of the other things is, after I've looked at the implant, the next thing I'll do is take the retractor out. And what I'll typically do is I'll just kind of lift the retractor about, 2 or 3 millimeters and just kind of like leave it there. And what I found is that sometimes, especially if you're very posterior, there's a little like venous plexus around the lumbar plexus that just bleeds. And if that's the case, I just want to make sure I get good hemostasis. I found that if it's very posterior, instead of going after it with the bipolar, I just use Surgiflow or Surgifoam and Fibrillar, and I just hold pressure for about 10 seconds, and I don't chase after it with bipolar cautery. I just find that it's a lot more effective. You're not kind of mucking around the nerves as much, and so I'll kind of check to make sure there's good hemostasis. If I'm kind of closer to 2.3 or even 1.2, I'll just kind of make sure that there is an issue with the lung or diaphragm, and then again, I'll kind of slowly take the retractor out. As far as closure, same thing. I'm being careful not to imbricate the nerves, both the ones that go to the abdominal musculature as well as the ilioinguinal, iliohypogastric. So I'm just kind of closing the fatty layer and then deep dermals and skin, but there's kind of no closure of those intercostal muscles, or if you're lower down, the obliques. And so, the risk of a hernia is minimal to zero, especially if you're going lateral. Typically, your hernias tend to be more central, so have not had any hernias due to not closing of the fascia. So I don't bovie through it, and I don't close it at closure. So that's kind of the lateral and kind of the basic steps. And again, it's one of those where, for me, if we're doing a T-lift, which is pretty rare, I'm probably doing most of the case.
Oh, you said
If we're doing a lateral, my residents and fellows, I'm just kind of sitting on the sidelines by the end of their rotation.
That's pretty good, Tony. I mean, you can see, guys, there's a bunch of little tricks and little nuances of each step that he's doing it. That thing, for example, at the end, that he lifts a little bit the retractor back, waiting for a bleed coming up. You're a new guy, an experienced lateral surgeon. Once you put the cage, you think you're done, and you just put something and you pull the retractor out, and there you go. The patient wake up then later on with a femoral nerve, and you blame on the company, on the monitoring, you name it, and the story is the patient may have a hematoma, So every step is very important, And don't forget, 80% of the complications happen on the last 20% part of the cases, That's when you really screw it up. So that's very good, Tony. I really appreciate it. So we're kind of getting back on time. So Neil, I think that we can pick up lunch, and then the people come with the lunch in here, and you start giving your talk. You're okay like that? Okay, guys, go and get some lunch.